Good morning, everyone. I'm Samantha Gherkin. I'm an employment lawyer here in Franklin, Tennessee, and along with John, I'm a member of the MT SHRM Programming Committee. I'm so glad you reserved this time in your day to join us for this very relevant discussion around Pharmacy 101 trends and best practices. In today's discussion, we'll explore pharmacy benefit managers, how drug manufacturers impact pharmacy spend, and GLP-1s like Ozempic and Wegovy. First, a few housekeeping items. Our speaker today has prepared a special presentation for you. We welcome each of you to participate by sharing experiences and questions using the chat and Q&A functions. If there are multiple questions, we'll lead a Q&A session at the end of the presentation. Also, we would love to hear your feedback after this webinar. There will be a short survey provided at the end of this presentation. We use this data to ensure we continue to provide you, our members and guests, with speakers and topics that are relevant and interesting to you. Finally, a follow-up email will be sent to all attendees a few days after this webinar with CE credit information. Now let's jump in. I'll let Brandon introduce himself.
Awesome. Well, thank you, Samantha, and good morning or good after. I guess it's still morning technically, so we're going to go with good morning. So good morning, everyone, and I'm grateful to be with you here this morning to talk a little bit about pharmacy. And if you'll give me just barely 1 second while I get my screen shared here. And maybe Samantha or John, if you can help me out and let me know if we have, can you see the presentation at this point?
I can see the presentation. It's not in slideshow mode yet.
All right, I just put it in slideshow. Let me stop sharing here. That should do the trick. Does that work?
It does.
Awesome. Well, a quick intro for those that I haven't had the opportunity to meet yet. My name is Brandon Webb, and I'm a vice president and benefits consultant here at Scott Insurance, and have been in the industry almost 21 years now. So I've been around the block a time or two, and I've learned the business what I call the hard way, and so I come to the table today with a lot of industry experience, and I hate to use the term expertise, but I'm passionate about the pharmacy space in general because I believe it's one of the growing components that I believe is causing our healthcare spend to really balloon out of control. And I think there's a number of things that can be done to help bend the cost curve down. And we'll spend a little bit of time scratching the surface on some of those topics today. And hopefully you'll walk away at the end of this session with a few tips or tricks or best practices that you can take back to your respective places of employment that you'll find helpful, that potentially can be implemented there to help manage cost on your front as well. So with that being said, let's jump into the data here. And so I've got just a very simple agenda that we'll spend kind of talking a little bit about the pharmacy ecosystem, in large part the influence of pharmacy benefit managers on the pharmacy ecosystem, because that's in large part who I guess we on the employee benefit side of the equation interface with more often than not. We'll talk about drug rebates and whether or not they're a good thing or a bad thing. My opinion has changed probably over the last decade that drug rebates are part of the problem. And so we'll spend some time talking about that. And then, of course, there's always a number of hot topics that are relevant to the topic or the conversation we're having today. There's a recent J&J pharmaceutical lawsuit that we'll spend some time talking about. We'll talk about Mark Cuban's cost plus drug program, but specifically the acquisition cost model that certain pharmacies or PBMs are deploying these days. And then we're also going to talk about a concept, that's been around for decades called comparative effectiveness research and analysis, and talk about how we do things differently in the United States when it comes to the approval of pharmaceuticals that hit the market compared to how other countries manage it. And unfortunately, we don't necessarily do it a way, in my opinion, that makes a ton of sense. And then, of course, probably the hottest topic of the pharmaceutical industry these days are GLP-1s, both the type 2 diabetic versions and as well as their weight loss brothers and sisters. And so, and then of course we have plenty of time for questions. And so the way that I've organized this out is we'll probably spend around the first half of our session together talking about the industry as a whole, and then probably the other half of the conversation today talking about some of these hot topics and issues that I've just briefly mentioned. So if you have questions as we work our way through this, I would welcome them, because ultimately I want this to be helpful for you. And if you've got specific questions that we can stop and answer or talk through, I welcome that, because ultimately I want to talk about the things that are important to you, not necessarily what I've prepared. And so I'm happy to take this conversation or presentation any direction you'd like for me to. So with that being said, where do we really begin? And this is a slide that I've used in the past when I've done similar presentations to this or spoken in live settings over multiple hours. And I condensed this slide down and eliminated probably 2/3 of the words or the taglines or the analogies that are on here. But the reality is the pharmaceutical space or the industry is a very complex industry. There are many different entities and layers to this, or what I call, there's a lot of people with their hand in the cookie jar, if you will. And so we're probably going to cover 1% of all of these issues today. And we're going to try to keep it fairly high level. But the reality is we could spend days and days, if not weeks and weeks, talking through the different layers and components of the pharmacy ecosystem. But we're going to keep it relatively high level. And I look forward to where our conversation ultimately takes us. So before we get into some of the nuances and the specifics around pharmacy benefit managers, this has always been helpful for me to use as sort of a level set so that we all have a general understanding of how a drug is ultimately manufactured and then makes its way into the hands of a consumer or a patient. And so the genesis of this process really begins, at least on one side of the equation, with a healthcare provider working with their patient to treat a specific condition or symptom of a condition that is subsequently provided a script for, that ultimately makes its way to a retail pharmacy that dispenses that drug to the consumer, and they obviously begin to take the medication. And so with that being the genesis of sort of the process, I think it's important for us to look at how a drug actually makes its way from the manufacturing process all the way to the pharmacies that ultimately lead to it ending up in the patient's hands. But then I think it's also important for us to spend a few minutes talking about the pharmacy benefit manager and how it influences the process, and talk through at a very high level. So I'm using the term a 10,000-foot perspective. And again, I've got a different slide that I use in different settings, but it becomes so large and there's so many different boxes and arrows on the slide that you can hardly read the words inside the boxes. They get so small if you fit it on one slide. So we're going to keep this very high level. No, there's more to the story than what we're going to talk about here. But let's get into it. So drug manufacturers with, like the likes of Eli Lilly or Novo Nordisk or Merck or Teva or AbbVie, these entities manufacture drugs and then they set pricing for said drugs, right? They in turn sell those drugs to very large drug wholesalers or drug warehouses that they purchase, they inventory and store these drugs, and then sell those drugs to dispensaries, i.e. pharmacies, and for the most part, they sell these drugs to pharmacies who then in turn sell or dispense drugs to the end consumer. So very simple at a high level, right? The other side of this equation is the influence of the pharmacy benefit manager. If it ended there, before we jump into the PBM space, if it ended on the left-hand side of the equation, the drug manufacturers obviously making money based on them manufacturing the drugs. The drug wholesalers are then marking the drug up to make a profit as well. And then the pharmacies are also marking the drug up. So there's a couple of intermediaries, if you will, before it gets to the patient or the consumer. And the prices at retail can vary wildly from pharmacy to pharmacy. Even the same big brand or big box retailer in different markets can have different prices at retail for the same exact drugs, just as an example. And so the pharmacy benefit manager then jumps into the equation here. And ultimately, what the primary purpose of a pharmacy benefit manager is to provide pharmacy benefits to health insurance companies and employer-sponsored health plans, amongst others. So we get into the Medicare space, there's support there, but we're going to sort of eliminate all of that for the purpose of our discussion today. So they then contract, pharmacy benefit managers then contract with these health insurance companies and large employer-sponsored plans to provide a number of services. So a suite of services, formulary development and management, utilization management, or other cost containment strategies like prior authorization, step therapy, et cetera. They do a number of different things. And so they capture the membership, if you will, or the volume of people that they can then have under contract. And then they go back to the retail pharmacies and they negotiate drug discounts from the average wholesale price of a drug. And I'll give you an example of what that is here in just a few minutes. They also negotiate network inclusion or steerage. So think of it as a scenario where they're taking this large population of people that they have under contract from their relationship with Cigna or United Healthcare or Blue Cross Blue Shield or Aetna, as an example. And they're going to the retail pharmacy and saying, hey guys, I'm going to include you in my network and I'm going to steer my membership to your pharmacies to buy their drugs from you. But in exchange for that, I want you to give me a discount on the drug that I'm going to essentially pay you for on behalf of these health insurance plans. And so they do that. And then they also guarantee the payment. So essentially they're saying, hey, and by the way, we're not going to turn you, Mr. Retail Pharmacy, into a collection agency. We're going to guarantee the payment for that particular drug contractually. So they essentially, and I'll give you a quick example here so that it makes a little more sense, but let's assume that the retail pharmacy says, hey, we'll sell you drug A at a 25% discount, just as an example. Well, then what the pharmacy benefit manager would do is they would in turn sell that same drug A, back to the health insurance plan or the employer-sponsored plan at, say, a higher cost. Let's just say that they sold it to the health plan at a discount of only 20%. And so they basically created a 5% margin for themselves as one of the revenue streams that they can generate as a part of this entire complex, jumbled mess, if you will. And so that's one of the ways that the pharmacy benefit manager kind of has its special place in the sun in this entire ecosystem. So essentially, it's a very complex and complicated intermediary between health plans and pharmacies, but then it gets even more complicated as you'll find out here momentarily. So PBMs also work with and negotiate directly with drug manufacturers kind of across the top here for rebates or discounts on their medications that are paid to the PBM directly in retrospect. So essentially, they're doing this. Drug manufacturers are willing to provide rebates or discounts to PBMs because they want preferred placement on their formulary. So for example, if AbbVie has, just to use a real example, if they have a drug, an immunologic in the adult inflammatory condition, and I'll use the most popular one that's ever been on the market called Humira. If Humira is preferred on the formulary with any particular PBM, maybe above another adult inflammatory medication made from a competitor like Novo Nordisk, for example, they will pay the pharmacy benefit manager huge sums of money in exchange for that placement on the formulary. And so what that then did is it created another or a second revenue stream for PBMs that they then have funds that they can do something with. And so historically, rebates and discounts were not that they weren't as big a component as they've become probably the last 5 or 6 years. So today, just for perspective, rebates represent roughly 40% or more of the total PBM, the PBM ecosystem, if you will, or maybe a better way of phrasing it is rebates represent about 40% of the drug costs that you're paying for drugs in your health insurance program today. So it's become significant. And they then have a third way that they also make money is they jumped back in the 1990s. They jumped into the late 90s, early 2000s. They jumped into the actual dispensary space here in the middle, and they started their own pharmacy. So they started their own mail order pharmacies for maintenance medications and their own specialty pharmacy to dispense and to drop ship specialty medications or limited distribution drugs from their own pharmacies directly to the consumer as well. So they started out as this sort of intermediary, and we'll talk a little bit about the genesis of and the historical context of the PBM industry, but they basically have got their hands in all these different elements and components of the industry, and frankly, it's why costs are so high today. So moving forward, I think it's helpful also when we have these, when I do these sessions and we have these conversations, I think it's helpful to have a little bit of a historical perspective of how we got from where it all started to where we are today. And so back in 1968, Pharmaceutical Card Systems, it later was rebranded as PCS Health Systems, became the first PBM. And in the 1980s is really when we started to see PBMs become major players in the pharmacy landscape. And so at the time, there was a number of what I would call small and mid-sized PBMs, but their primary focus at the time was really around developing simple formularies, essentially to steer members to the lowest cost drugs. Also in the 1980s, PCS developed the first electronic claims processing system that's become kind of the genesis of what the PBM the technology side of the PBM industry has become today, and the fact that drug claims are adjudicated and processed and paid in real time. So when you go to a pharmacy, for example, when you go to a pharmacy and you pick up your prescription, the pharmacy has to be able to have the data of, number one, are you eligible for the plan that you're presenting a card for? And what is your cost share? What do you owe? Do you owe a copay? Do you owe $500 because you haven't met your deductible yet? Do you owe 20% of $500 because you've met your deductible, but you've not met your maximum out-of-pocket expense? So all that information has to be available to the pharmacy that's dispensing the drug in real time. And so the genesis of that system started in the 1980s, and obviously has evolved and developed over time. But that was originally what PBMs were for. It was really just around trying to steer folks to the lowest cost drugs and then to process claims. In the 90s, we saw the first cost containment strategies being deployed that really focused primarily around drug to drug interactions. So think of it, if you take drug A combined with drug B, then these specific side effects are going to happen. And so they're hyper-focused on engaging both members and the doctors. They would send letters to doctors. They got hyper-involved in the process from a clinical perspective. And then costs began to rise, and they also were hyper-focused on driving members to lower cost drug alternatives when one was available. So if you were taking a higher cost drug when a lower cost alternative was available, they would actively seek you out, call you, send you letters in an attempt to try to transition you or transfer you to the lower cost drug. Those practices in part are still happening today. And in the 90s, we also saw the first large scale acquisition of a PBM that took place, and three or four of them happened, the largest of which was Merck's acquisition of Medco, which was the largest PBM at the time and was still the largest PBM in the country prior to Express Scripts acquiring them I think it was 2011 or so, but we'll get there here momentarily. But the drug manufacturers were the ones that were actually buying PBM. So Eli Lilly bought PCS, Merck bought Medco. There was another drug manufacturer at the time that bought another PBM. And so the drug manufacturers wanted to get into this PBM game. And in the 2000s, the first PBM, and I mentioned this a few moments ago, the first PBM entered the dispensing arena in the 90-day mail order home delivery option for maintenance medications. In the 2010s, we saw the specialty drug pharmacies begin to pop up and the clinical management and support around those specific drugs. We also saw the first introduction of manufacturer patient assistance programs. So think about manufacturer coupons, copay assistance programs, which were challenging for PBMs at the time, and still frankly are today, but they were challenging for PBMs at the time because PBMs were developing formularies and were trying to steer folks towards lower cost drugs. And what the coupons were doing, and again, we've got to go way back and think, well, there was a lot more copay plans, based plans back 15 years ago than there are today. And so what these copay assistance programs were doing is making the member whole for taking their brand name drug over a lower cost generic and keeping the member whole, but it was costing the health plan significant dollars behind the scenes that were often forgotten about. And so again, probably the first time we begin to see some of the games that are played even today in the PBM space. So then we move forward to 2011, and we saw the first large consolidation in the PBM space when Express Scripts acquired Medco, and they became Medco was the largest PBM at the time, but Express Scripts was not too far behind them from a size perspective. But basically, when that happened, Express Scripts became an absolute whale in the industry. It then happened again in 2015 when OptumRx acquired Catamaran. And Catamaran, we used to do a good bit of business with Catamaran at Scott. And Catamaran at the time was the most technologically advanced PBM. And Optum wanted their technology, number one, and they also wanted their volume so that they would basically double in size. That would put them in closer standing to where the Express Scripts Medco relationship from a size perspective was. And essentially when that happened, they became one of the big three. CVS was essentially already there. Walgreens in 2016 formed a strategic alliance and launched Alliance RX and Specialty Prime. Walgreens didn't necessarily get into the PBM business, but Prime Therapeutics is a PBM that's owned by 18 Blue Cross and Blue Shield plans. And so there was a strategic alliance with some of the consolidation that was happening in the marketplace. They felt the need to do something similar and launched that in 2016. And then in 2017, we're all familiar with CVS Health when they acquired Aetna. And then the following year, Cigna acquired Express Scripts. And the year after that, Anthem launched IngenioRx, which was subsequently renamed last year to Carelon RX. And so we saw this massive vertical integration and consolidation with health insurance companies. And frankly, it baffled many of us in the industry because we weren't quite sure what the angle was. And so just to give you some perspective about the magnitude of this particular industry, PBMs currently have approximately 275 million lives under management last year, which was up from about 60 million lives in 1990. So you can see there that the influence that the PBMs have in the pharmacy ecosystem has grown in significance, and now is they essentially have the lion's share of those covered in by a plan in the country. So currently there's 66 independent PBMs that are operating in the US per the National Association of Insurance Commissioners. And the big three control 79, just shy of 80% of the market share. CVS Health and Caremark control 33% as the largest. Express Scripts or Evernorth, I'll make a comment on that here momentarily, control 24%. And then OptumRx and United Health Services Group control 22%. One of the components to be on the lookout for, just as if you want to write this down, but part of the consolidation of the big three with the integration with health insurance companies, part of that was part of it was to be able to provide health services, right? And there's a new process called intercompany eliminations. It's a tax play. It's part of the IRS code. I'm not an accountant, so I'm not here to tell you what's going on. But essentially, health insurance companies today are basically always one step ahead of us. And it's the next big way that they're profiting on the backs of employers and employer-sponsored plans in the industry. So if you want to write that down, I'm happy to circle back to that and add some additional commentary if there's questions on that front. But last year in 2023, the PBM industry was a $525 billion industry with projections that it will eclipse the $1 trillion mark by 2031. So unfortunately, it's not going anywhere, and it's going to continue to be a challenge and a problem, at least in part. I think for all the good that they've done over the years, it's gotten a bit out of control. And so just for context and perspective, this is what the horizon looks like, according to some credible research and data that's available out in the marketplace. I'm going to pause briefly in case there are any questions. John or Samantha, are there any questions that we need to slow down and address before we continue to move forward?
Nothing in the Q&A box at this point.
Awesome. Thanks, John. So I mentioned the vertical integration, and this is just a snapshot of what that looks like. And so you can see here that Aetna, the health insurance company, sit across the top. So Aetna is the health insurance company. Caremark CVS is the PBM, and the specialty vendor is CVS Specialty. Cigna owns Express Scripts and Accredo, which is the specialty pharmacy. United Healthcare owns Optum Rx, and then Briova, which is the specialty pharmacy arm that I believe is going through a rebranding, if I'm not mistaken. So that logo may be going away and changing here in the near future. But essentially, the big three are getting bigger, and it's becoming harder and harder to have visibility into what's really going on behind the Iron Curtain, which is where the bulk of the business in the pharmacy ecosystem takes place, unfortunately. So there's two different, when we talk about PBMs, there's two different scenarios or options, if you will. There's a carved in version or contract with a PBM, and then there's a carved out. And so I thought it would be helpful for us to highlight the differences between the two very quickly before we continue to move into some of the funner parts of the discussion this afternoon. So a carved-in pharmacy is essentially a benefit, a pharmacy benefits that's baked into your medical plan. So think if you're fully insured or you're a smaller self-funded plan, you're probably carved in. They're typically run by the carrier or a third-party administrator, and there's virtually no flexibility that you have with the benefit other than maybe picking and choosing your copays. So you've got no visibility into your performance. There's no way for you to really hold the carved in vendor, pharmacy benefit manager vendor, for their performance in any meaningful way. And again, it all happens behind an iron curtain. There's virtually little to no visibility from a performance perspective, and there's no client specific guarantees either. A carved out pharmacy arrangement is a benefit that's essentially peeled away from the medical plan itself and is managed outside of the health plan's influence. Now, they're still bolted together and they still function like a carved-in pharmacy function from a member end user perspective. So they still have an ID card. It still has medical information and pharmacy information on the ID card. But the contract itself is managed outside of that relationship with the medical vendor or the TBA or the carrier itself. And the benefit for you as consumers or buyers or leaders within your organizations that work around employee benefits and health plans and pharmacy contracts is that there's significantly more visibility into the contract, the performance of the vendor, that also oftentimes includes auditing rights and client-specific pricing, rebates, and performance guarantees. And so we typically see carve-out arrangements happening in the mid-size to larger self-funded health plan space and health captives and other alternative funding arrangements that offer carve-out options as well. So what do PBMs actually do? I've talked a little bit around this, but on the base level of services are at its core, they're originated as a claims processor, number one, and a formulary, essentially formulary development and management. Drug utilization review is another component that really draws into some of the cost containment strategies around prior authorization, step therapy, and the day supply. They also provide services around fraud, waste, and abuse. And so think an example, probably the best example of fraud, waste, and abuse is probably in the opioid space. So for example, if they see a member that's frequently filling medications for very strong pain medications, they're probably going to intervene in that, in that situation and begin to investigate and figure out what may be going on. And then there's also a number of clinical services, patient services that that a PBM provides, certainly reporting emerging issues or updates, things of that nature. Mail order and specialty pharmacies. So their own pharmacies, by and large, most of your larger PBMs all own their own mail order and specialty pharmacies. And then they're also in the communication space as well. But from a cost containment strategy, which is really where I believe a lot of their value resides, is in the utilization management strategies and tools that are available or that are required, frankly, oftentimes. So a prior authorization is essentially a scenario very quickly here. A prior authorization is essentially think of it as a gatekeeper that you don't just get to take the medication because you want it or because your doctor prescribed it. You've got to meet a certain set of clinical criteria in order to be authorized to have the pharmacy fill that script on your behalf for whatever condition that it might be required for. Not all PAs are identical. A lot of PAs happen automatically. Probably the best example of a prior authorization, because we'll spend some time talking about GLP-1s here in a few minutes, but historically, the only prior authorization requirement for a GLP-1 drug, for example, with a type 2 diabetic, was, did you have a 90-day prescription for metformin, which is a very inexpensive, low-cost drug that costs about $3 for a 30-day supply. Did you have a 90-day prescription filled for metformin? And if that box was checked, then the PA was automatically approved and you could get your Ozempic or your Mounjaro or whatever the case may be. Step therapy is a requirement that PBMs deploy. Goes back into a bit into the rebate game and a bit into the formulary management, where they might have a series of other drugs that are preferred on formulary. And if you show up to a pharmacy with a script that you try to fill, it will reject for a step therapy requirement because they want you to try one of their preferred drugs before they allow you to fill the drug that your doctor prescribed. So that's not necessarily always about are the drugs that they want you to try lower in cost or more effective than the drug your doctor prescribed. A lot of it has to do with which drugs the PBM has the best contract with from a rebate perspective. And again, I think that's part of the problem that we have in the industry these days. And then quantity limits, of course, naturally, there's certain drugs that they limit the supply that you can acquire at any one given point in time. And that is less about cost and more about the safety and the efficacy of any particular drug. From a pricing perspective, network discounts, I explained that a little bit when we talked about the life cycle of a drug. Rebates are a big part of this. We've got a couple of slides dedicated to that, which I'll save my commentary for when we get there. And then volume purchasing in mail and specialty pharmacies. When the PBMs own the pharmacies, they're buying the drugs. They can essentially cut out a small portion of their margin, which makes it more attractive for the plan sponsors or the health insurance companies to drive their membership to purchase their maintenance medications directly from the PBM versus the retail pharmacy. And they're able to make it a little more attractive from a cost perspective as a result. And then the drug mix, the formulary. The formulary, and I've got this, I'm using quotation marks here because the PBMs will all tell you that they have a lowest net cost formulary that was developed by their P&T committee, that stands for Pharmacy and Therapeutics Committee, which basically is a very fancy term for they get to pick the drugs that are on the formulary. The problem is they don't give us as consumers or as consultants or you as plan sponsors any sort of visibility or insight into whether or not the drugs that are preferred on their formulary really are helping achieve the lowest net cost. And so again, I go back to the Iron Curtain comment that I've made a few times already this afternoon. And the reality is that the lowest net cost could be a real thing, but basically they're saying, well, we can't prove it to you, but we want you to take our word for it, because that's what our fancy P&T committee did, which obviously there's some financial components that are I would imagine to be a part of that in terms of how drugs make their way onto a formulary. A generics policy, so generic strategy. Most plans today probably have generic fill rates in the 80 to 90% range, depending on some other nuances there that I won't get into today because we just don't have the time. And then copay differentials in terms of stacking lower cost drugs into the preferred tier so that they carry a lower copay. And then also step therapy by requiring that members take certain drugs before they're permitted to fill more expensively or maybe non-preferred drugs within the formulary. Pharmacy networks, I think given the fact that we're getting close on time here, I'm going to kind of breeze through this, but essentially the idea of pharmacy networks in terms of the services that a PBM provides, think of them most of them being very large and robust, including all of the major pharmacies that we're all familiar with, Rite Aid, Walgreens, CVS, the big box retailers like Walmart, Target, the grocery stores, Publix, Kroger, et cetera. They're all going to be a part of most networks. And oftentimes, all of your mom and pop stores in any one geographical region will be as well. And by and large, think of pharmacy networks from a cost savings standpoint being the narrower the network, the deeper the discounts you typically will be able to achieve because there's more steerage that's happening to a narrower network. And so the pharmacies typically will give a better discount as a result of the steerage that they're picking up. So there are there's really more than four, but they really fall into four different categories when we talk about different PBM pricing models. So the most common is a traditional PBM, and all of the big three are traditional PBMs. And so in essence, a PBM reimburses the pharmacy one amount, charges the plan sponsor a higher amount, and keeps the difference, or we call it spread, as profit. I mentioned that on the first or second slide. And there's zero transparency into the PBM's profits. They're not going to tell you anything. You've got no visibility into it. You don't have any idea what rebates are being collected or paid, et cetera. It's all based on it's all happening behind that iron curtain. A pass-through PBM are PBMs that began to grow in popularity probably 10 years or so ago. And in this arrangement, the PBM reimburses the pharmacy one amount and charges the plan sponsor the exact same amount that they bought the drug for. So they're not making any spread pricing. And the way they make their money is through admin fees on a per claim basis or on a per member per month basis. But they can and still do have other forms of revenue because rebates are still paid on pass-through PBMs. And most pass-through PBMs still have a very large GPO contract through the likes of one of the big three rebate aggregators, they're called, or GPO contracts that manage rebates. And so they're still a part of the ecosystem, if you will, where pass-through PBMs are still making money on the rebate side of things, even though they're not making spread pricing like the traditional big three PBMs are. The acquisition cost plus model is where the PBM charges a plan sponsor the cost to acquire the drug at a PBM-owned mail or specialty pharmacy. So the best example here is Mark Cuban's cost plus. I'll save the bulk of my commentary for that side because I think it's relevant in the J&J lawsuit scenario that's out in the market as well. And then there's a number of alternatives and different models that have popped up and that are all based on the national average drug acquisition cost pricing models. And so, but they're all so new and different. And I use the term shiny pennies, like each one would need to be evaluated and determined whether there's any value there if it's real value or just perceived value. So basically being, is there really any money to be saved there, or is it just a bunch of shiny pennies that look good and sparkle and but there's no real meat on the bones there, if you will. So that leads us to rebates. So what are rebates? So rebates are financial incentives that manufacturers use to increase their market share, ultimately gaining preferred placement or preferential placement on a PBM's formulary. Rebates are negotiated and paid to PBMs as a percentage of the drug's acquisition, wholesale acquisition cost, or WAC is a term that's used there. And then rebates are shared with plan sponsors in part at times, and in some cases with members also at the point of sale, depending on the PBM contract. So this gained some traction 3 or 4 years ago. The concept of OptumRx had a program where they were going to do some point of sale rebates for members that ultimately blew up in their face and became a massive issue. And ultimately that's largely a thing of the past at this point. So I asked the question, are rebates a good thing? So rebates are massive revenue generators for PBMs, right? And there's been a massive growth in rebate dollars post the vertical integration we talked about with the health insurance carriers. But there was also a component, if you start putting the pieces together, on the heels of the ACA's medical loss ratio requirements was a driver in that. So I have a client that has about 13,000 members, that was earning about right at just shy of $1 million in rebates in 2016. So there was 13,000 belly buttons on the plan. And last year, their membership is slightly down. So they were like 12,800, so a couple of hundred members short. But 12,800 members in 2023, and they collected north of $9 million in rebates in 2023. And part of that was the reality, or as a result of the fact that health insurance companies in the fully insured space were required to spend, and I'm going to use the 85-15 example. There's an 80-20 example out there too, but they required, the ACA, the Affordable Care Act, required that for every dollar that a health insurance company collected in premium, they had to pay out 85 cents in claims. They can only use 15% or 20%, depending on your market segment, to operate their business, make profits, et cetera. And so rebates became health insurance companies' profit centers. So they would jack the cost, again, after the consolidation. So now Aetna owns Aetna owns CVS, or CVS owns Aetna, and Cigna owns Express Scripts, right? And the Blues have Prime Therapeutics or Carelon for the bulk, for the most part. Well, now they're able to say, hey, well, we want rebates to grow significantly because we don't care. We can underwrite for the increased cost for raising the prices of drugs, but we'll just collect it back on the back end from you as profit that's not a part of that MLR equation. So that was in part, that was part of, I believe, the driver, the growth, the significant growth of rebates that we've seen since that 15, 16, 17 period to where it is today. And so the other concept that became popular was 100% rebate pass-through contracts. And is that a myth? Well, rebate aggregators like ESI's, Ascent Health Services, they collect admin fees on rebate that it collects and manages. And so they're incentivized. They charge a percentage of the rebate dollar. So the fees can run between 5 and 20%. And so in reality, the higher the rebates, the more money the PBMs are making. And so there's this massive misalignment of incentives as a result of all of that stuff, right? So they're incentivized to leave higher cost, heavily rebatable or rebated drugs on formulary over lower cost generics and biosimilars. And AbbVie, which is the manufacturer for Humira that rolled off patent a number of years ago, and biosimilars have been available for a couple of years now. Humira is still preferred on formularies with Express Scripts and many other PBMs for that matter. But what they did is they cut a bundle deal that included Skyrizi and Rinvoq, which are two other specialty biologics, immunologics in that adult inflammatory space. And what they did was they said, hey, we're not going to pay you rebates on Skyrizi and Rinvoq if you don't leave Humira on a formulary in a preferred status. And so even though there are lower cost biosimilars available to Humira on the market today, many people are still taking it because the drug manufacturers have essentially handcuffed the PBMs. That's leading to us all paying higher drug cost. So then CVS recently removed Humira from the formulary on 4/1. So just a couple of weeks ago. I'm not sure if you guys have seen that yet or not, but they removed it from the formulary on 4/1. And so when I first saw it, I was like, man, that's a huge win for the industry. Maybe Ascent and ESI and others will follow suit. But I started to do a little more digging, and I came up with, well, that not necessarily so fast. So the reason that CVS removed Humira from the formulary, even at the risk of losing some rebate dollars on Skyrizi and Rinvoq, CVS is a part of a joint venture with another drug manufacturer that developed a biosimilar to Humira called Cordavis. And because they own it, they basically have acknowledged on a recent earnings call that another industry partner, friend of mine, was privy to. And on that earnings call, basically they acknowledged they built in what they were losing on Humira back into Cordavis. And the financial impact on their earnings was significant. So again, a lot of this stuff that I keep mentioning that it's not a good thing. It might look really good on paper, but when you really get kind of below the surface, that iceberg is quite large and massive. And I'm going to skip through this just in the interest of time. So hot topics. So recent pharmacy industry events. So the PBM industry continues to generate headlines with tons of negativity around the big three. So Tyson Foods fired CVS for an upstart PBM, basically a brand new PBM. So it's the first Fortune 100 company to fire one of the big three to work with an upstart PBM. So that hit the news here last year, that went live with the new PBM for 1/1 of 24. And then probably the two hottest topics in the pharmacy industry today is the J&J Pharmaceuticals lawsuit, where an employee is alleging that J&J has overcharged or overpaid their PBM for covered medications offered within the employee benefit plan structure, and that it also alleges that they violated the company's fiduciary duty under ERISA and mismanaged the benefits that resulted in higher costs for prescription drugs, higher premiums, deductibles, co-insurance, co-pays, and lower wages or limited wage growth. So the lawsuit is specifically focused on overpriced generic drugs, and more specifically, overpriced specialty generic drugs. And so the lawsuit highlights the risk that I think we all carry as working with our health plans and in the space, but it highlights the acquisition cost models like Mark Cuban's cost plus drugs, and the need for due diligence around comparative effectiveness research and analysis. And so just quickly here, I wanted to jump through and highlight the J&J just to give you some perspective here. So on this particular graph, you can see here that there's a list of 4 generic drugs. So the markup, the price that J&J paid per script, you can see here that it was, $5,000, $16,000, $13,000, and $15,000. And if you look over here at the True Data average script price, you can see there that they are drastically lower, drastically different, right? And furthermore, like if we go to Mark Cuban's Cost Plus website, this is the example that is on his website this morning when I pulled it up. So again, they're trying to provide complete and full transparency. So what this does is it's taking a drug that through one of the big 3 PBMs costs $9,657. And they're highlighting the fact that through Mark Cuban's Cost Plus drug program or pharmacy, they can acquire that same drug, identical drug, for $31.20. They then are showing you exactly what they're marking it up. So they're charging a 15%, they charge 15% markup on their drugs for $4.80. And then they also show you the pharmacy labor that they're charging the member for the pharmacy dispensing and filling the drug. And then they're also charging you and showing you exactly what they're going to charge you to ship it to you directly from their pharmacy to your front door. And so for $41, the same drug can be had versus the $9,657 that your health plan or that your members may be paying in their deductible phases or coinsurance phases for that same drug through one of the big 3 PBM. And so I set this out there to just highlight the inefficiencies and the unknowns and the motives being the misalignment of motives and incentives in the pharmacy and the PBM space. Because the reality is that drug costs could probably be substantially lower if we had visibility into a lot of this stuff prior to this lawsuit and prior to the launching of Mark Cuban's Cost Plus Drugs. Any questions on this before we jump into GLP-1s to land this plane?
We don't have any questions in the chat, so unless anybody wants to raise their hand, I think we can just go on to the next. Thanks, Brandon.
Awesome. Perfect. We'll skip some of this stuff because around comparative effectiveness and go straight to the GLP-1. So I've used this slide for years, for a couple of years, and I used to call this slide the next big thing, but the last time I did this, I crossed out next and put the now big thing because it's here and it's becoming a beast. And so GLP-1s in 2022 saw a 30 to 50% increase depending on the category of the drug. In 2022 compared to 2021, there was a massive increase again in 2023. So the same client, just for context, that saw their rebates change from 2016 at $1 million to $9 million in 2023. They spent $5 million more last year on Ozempic and Mounjaro alone than they did in 2022. So in 2023, they spent $5 million more on Mounjaro and Ozempic than they did in 2022. And so there are additional GLP-1 drugs in the pipeline. And Novo Nordisk, actually, who is the manufacturer for context around Ozempic and Wegovy. And so let me level set here on what these are. So Ozempic is semaglutide, all right, and has an FDA indication specifically for type 2 diabetics only. Wegovy is what happened during Ozempic's clinical trials. They found out that members, once they got to the higher doses in the clinical trials, started losing weight. And so they leaned in on that in a subsequent clinical trial, and they determined that as they continued to dose the semaglutide, the doses up, as they increased the doses, folks and people that were a part of the blind clinical trial were losing even more weight. And so Novo Nordisk launched Wegovy, which is an identical medication to Ozempic, all but a stronger dosage. They launched Wegovy, and it has an indication, or had an indication originally just for weight loss. Ozempic does not have an indication for weight loss. So you can't get an Ozempic prescription through the traditional PBM model or through your health plan for weight loss. It's only available to type 2 diabetics, but you can potentially get a Wegovy prescription which is again an identical medication. Mounjaro is tirzepatide, and it's a combination of a GLP-1 and a GIP, a GIP drug that's slightly more effective than Ozempic and Wegovy, both at lowering HbA1c levels for type 2 diabetics. But then they did the exact same thing and went through a different clinical trial and launched Zepbound at the end of last year. I think it was back in November, if I'm not mistaken. And Zepbound is an identical drug to Mounjaro. It's tirzepatide, but it's got an indication for specifically for weight loss. Now, Novo Nordisk has a new combo drug that's currently in development. And Novo Nordisk is actually paying. I've been told that it's in the hundreds of millions of dollars range for a head-to-head study against Eli Lilly's Mounjaro. And so when a drug manufacturer is willing to spend that kind of money on a head-to-head study, they are relatively completely confident and convinced that their new drug will outperform the drug that they're comparing it to. And so when that happens, if they're successful, this new drug from Novo Nordisk that is a GLP-1 combo drug, more similar to Mounjaro than Ozempic. So it's basically semaglutide and another drug, active ingredient. The cost structure in this sort of specific drug category is likely to change. And so the other, I think, component of GLP-1s that has happened here recently is that the weight loss versions of these drugs are getting and they are obtaining new FDA indications for different disease states. So Wegovy at the beginning of March, so about 6 weeks ago, they got an indication for certain cardiovascular diseases. And so historically, the play for managing cost on health plans was to exclude coverage for the weight loss versions of these drugs. You can't exclude the ones for diabetics, but excluding the ones for weight loss like Wegovy, Zepbound, and Saxenda, they now can, patients that are obese, that meet the BMI criteria, that also have certain cardiovascular diseases, can now get a prescription through their health insurance plan for Wegovy, even though the weight loss category is excluded from coverage. So formulary exclusion is not likely a viable long-term strategy because they are going to continue to get additional indications. So there's a sleep apnea indication, there's a substance abuse indication, and many others that are currently being tested and in the pipeline. And so both Wegovy and Zepbound and Saxenda are incredibly active in that space, just as an FYI. From a weight loss, the weight loss versions of these drugs, just from a strategy consideration, to try to wrap this up here relatively quickly, long-term use in patients that are not obese is likely not viable from a cost perspective. Now, the PBMs and the drug manufacturers alike are marketing long-term usage is necessary to keep the weight off. And so they are prescribing and marketing to an angle that, hey, if you need to get on Zepbound or Wegovy or Saxenda for weight loss purposes, that you need to stay on this drug the rest of your life. The problem with that is that there really haven't been any long-term studies over the effects on the human body for being on these higher doses of these drugs over long periods of time. And so I'm not sure that we'll know about the safety and the efficacy of that particular strategy. But what we're likely to see happen in health plans, at least from my perspective, is the potential for short-term usage events, or maybe lifetime supply limits on the weight loss versions, where a health plan says, just like they do maybe for infertility, for example, or for a lifetime limit on bariatric surgery, they may say, hey, we'll pay for a 1-year supply of one of these weight loss versions of these GLP-1s, but once you've exhausted your lifetime supply, that drug will never be available to you again, regardless of the indication that it might be prescribed for. And so I think that, in combination with lifestyle modification support to ensure weight management and the weight loss is maintained once the medication is discontinued, has proven to be critical for most folks. They can't go back to doing the exact same things they were doing prior to taking the drugs and getting into a calorie deficit and exercising on a regular basis. They can't go back to their old way of living without the expectation that they'll gain the weight back. And then I also think at some point we'll start to see some usage in the pre-diabetic category, with the intention around trying to help pre-diabetics lose weight, to help them remove the need for long-term diabetic care. And if they do migrate into becoming an actual type 2 diabetic, removing the need for other costly treatments that can be a part of that if weight loss isn't achieved. And so I think there's a number of strategies that are being deployed there that we'll likely see happening over the coming weeks and months. Looking forward. So we're right at time. I'm going to stop my commentary here. I'm happy to hang out for a few minutes and answer questions for those that might have them, that want to stick around and just chit chat about a number of things. But again, I really appreciate you having me, John, Rochelle, and Samantha. I hope this was helpful and informative, and look forward to seeing you guys all soon.
Well, thank you, Brandon. It was informative for me, I'll say. I don't know anything about pharmacy benefit managers or anything you were talking about today. Obviously, I've heard of Ozempic, and I've heard of Mark Cuban's program and some of the news stories about costs for medication being completely out of control, like EpiPen, that kind of thing. So for me, it was all new and very informative, and we really appreciate having you here today.
Yeah, I'm happy.
If you have any further questions or you want to get connected with Brandon, please feel free to use